Hello, lovely friend. I am Dr. Mary Barson.
And I'm Dr. Lucy Burns.
We are doctors
and weight management and metabolic health experts.
and this is the Real Health and Weight Loss Podcast.
Good morning, lovely friend. Dr. Lucy here this morning. How are you on a beautiful Tuesday morning, unless it's Wednesday when you're listening to this, or even Friday? This morning, I am without Dr. Mary because I have a fantastic guest. You will love her. She is a wealth of information, and we are going to touch on some subjects that some people might consider to be a bit taboo. They're certainly maybe a little bit uncomfortable, but they need to become more comfortable. So I am super happy to welcome to the podcast Dr. Gab Staniforth. She is a GP in the lovely country town of Orange, and her special interests are menopause, vulval health, not ice vovos and not volvos, and transgender care. So she has got some really interesting things to talk to us about today, and I think you're going to love her. Gab, welcome to the podcast.
Thank you so much for having me, Lucy. I feel really humbled that you asked me to come and chat on a podcast that I've been listening to forever, it seems. So thanks for having me.
Oh, you are welcome. And so my lovely friends Gab and I met in person at the So Hot Right Now conference, which was a menopause conference way back in March now, organised by some fabulous medical doctors from Australia. And we happened to just sit next to each other, which was wonderful.
It was so good.
Yeah. So I thought last year we ran a big series on menopause. And I mean, this isn't just about menopause. This is really about women's health. And our podcast is called Real Health and Weight Loss. Not everything we talk about is around weight loss. Lots of it is, but not everything. And I think that talking about women's health, we need to be talking and using the right words to describe women's bits and pieces.
100%. If we don't have the right language around it, then we're just going to get it wrong, and women are just going to go under the radar and not get the help that they need. So we do have to get comfortable with the uncomfortable, and there's nothing like practicing to make it more comfortable.
Exactly. It's interesting because I think people do seem to be more comfortable with the word vagina. They use that a lot. I don't know whether it just sort of it sounds nice, rolls off the tongue. But some of our other words, nobody's using them.
Yeah, I think you're right. Even vagina is still something that is quite a taboo word. I mean, don't we get a big red mark against our name if we even name it on Instagram or Facebook, which is absolutely ridiculous. But I think, words like vulva or labia, I think it's probably twofold. There's a lot of people that haven't received the correct education around what language to use around genitals, for example. But also in the generation that I was brought up in, there was sort of a bit of, not a bit, but shame and stigma around genitals and sexual health. So anything that was referring to that, it was met with a little bit of a giggle, or sometimes you got into trouble for it. So, of course, there's a difficulty or a lack of education around using the correct terms, and that then transforms to women not being able to adequately describe their own bodies or recognise when things are going wrong.
Exactly. So I guess, now this is tricky because we're on a podcast, so people can only hear us. But if you were to describe all the bits and pieces, what is our anatomy?
I think some of the important things that I guess need to be covered, and I like to take things systematically, I guess. So maybe I'll go from the top down, but it is important to be able to name and talk about the clitoris and the clitoral hood, which it sits under. And then we've got all the outside bits of our genitals, which I guess under a blanket term would be called the vulva, but that involves the labia majora, which are the outside flaps, if you like, and the labia minora, which are the inside flaps. And then lying within them at the top end is the urethral opening, which is the opening from the bladder, if you like. And then we've got the vagina and the introitus, which is the opening to the vagina. And of course, part of the genitals also involves the perineum and the anus and perianal area as well, which we definitely don't use those words, do we?
No.
That's just naughty and dirty. But it's important because
everyone just calls it your bottom.
Yeah, bottom, front bottom, back bottom. That's how I was brought up. I didn't even know that I had 3 holes by the time I got my period. So isn't that like shocking?
Yes. I think it is. It's hard. And I think the words, we're not used to them. We don't like them. They're all there, and some of them do feel, it's a bit like scrotum. Scrotum's another word that nobody likes to say. It's sort of, I don't know what it is. It's like, ugh.
I think is it because it almost, I don't know, like makes you envisage it? I don't know. And then you go back to being a child and you're like, oh God.
Yeah.
Penis, bum, scrotum.
Yeah. I don't know. It's funny. Whereas, like humerus, which is your arm, like we just say that. Humerus, no big deal. I don't know. There's no overlay to it.
No big deal.
Yeah.
No.
Whereas, yes, you're right. And even like mons, people wouldn't know what their mons is.
Yeah.
So if you're listening thinking, yeah, what is the mons? It's that front, right at the front, I guess, for the, and again, what do we call it? The map of Tassie.
Yeah, exactly.
A little, euphemism for it.
Yeah. It's the front bit, isn't it? That's right on top of your pubic bone, where your pubic hair sits, or your map of Tassie, if that's how you choose to curate your pubic hair.
Yeah, absolutely. So, and even though pubic is another word that people don't sort of say.
Pubic hair, pubes.
Pubes, yeah, all of those. So I think that getting comfortable with those words is really useful, because that leads us into the next part of our conversation, which is when things go a bit awry down there. Again, hear me? I didn't even mean to say it like that. It just sort of came out. Down south.
We've got to let the audience be comfortable too and just ease them in. So I think down there is fine.
Yes. So there are things that do go amiss down there. So, and that's your area. Like you see a lot of vulval health. So perhaps can you step us through some of the things that you see commonly that women may not realise are either not normal, or B, they just put up with it?
Yeah, so there's quite a lot of things that commonly present, particularly now that I've started really focusing in on menopausal health, because believe it or not, a lot of these dermatological conditions in the vulva is skin, so it is dermatology that we're talking about. These things do actually get exacerbated with the hormonal changes that happen in perimenopause and menopause. And we see a big spike in the incidence of certain conditions around this time, including the genitourinary syndrome of menopause, previously referred to as vulvovaginal atrophy, which encompasses not only the vulvar and vaginal symptoms, but also now encompasses the urinary symptoms as well. So I think that the big things, or the most common things that I see coming through my doors, are the genitourinary syndrome of menopause, lichen sclerosis, CVVC, which is chronic vulvovaginal candidiasis, not to be confused with acute candida infections or thrush, and I guess, simple dermatitis as well, and psoriasis. They're the things that are not common, but they're the things that I would see most when I'm looking at people who are coming in with an issue.
Okay. So GCSM, or the genitourinary syndrome of menopause, can you tell our audience what is that?
Yeah, so when our hormones change and we lose estrogen, we have lots of receptors for estrogen and testosterone in our genital area. So that too is deeply affected around this time. We lose collagen, which makes the skin thinner and paler. And if it's thinner, then it's going to be more susceptible to trauma with any type of friction. And I'm not just talking about intercourse, I'm just talking about walking around, sitting, riding a bike. If things are really frail, then they're going to be disrupted down there, which is going to cause, obviously, symptoms of pain and itch and discomfort. In addition to that, our glands produce less secretions, which means we're not as lubricated, and that's where the dryness comes in. And that's a really uncomfortable state. And I think that everyone could probably, try and think about a time where they've had a really dry mouth. or even conjunctivitis where it feels like you've got sand in your eyes, I'm sure that would feel really uncomfortable if that was what you're walking around with in your pants. In addition to that, everything becomes smaller. So the labia minora, the inner flaps, actually can get so small that they disappear. The clitoris can get smaller, which obviously can affect function, sexual function. The clitoral hood can shrink and tighten over the clitoris, which once again can cause discomfort or a change in sexual function. And these changes are true too within the vagina. And within the urinary system, because the urethra is right there within the folds of the vulva, that can really alter urinary function. If the urethra kind of protrudes out, then that too is going to be more susceptible to microtrauma, which is an area where, bacteria can get in. And that's where we're seeing women all of a sudden getting recurrent UTIs again, or experiencing symptoms of dysuria, which is pain on urination, or urinary frequency, which might be during the day or be seen, getting up more times overnight. And I think with these particular symptoms, the urinary symptoms, a lot of women just put it down to, I'm getting old, or I have a cup of tea at night, or, it's not actually linked to hormonal changes. And I think that's where it's important to have these conversations using these words so that women know that, oh, this actually could be something to do with shifting gear in my hormones. And that's okay, because we've got really simple, effective treatment, which can not only help women feel better, but can also prevent the progression to really sinister things like urosepsis.
Yeah, absolutely. So I must say, I think it is amazing that you can just use some vaginal cream, like an estrogen cream. So you're replacing the hormones locally, and all of a sudden you're not getting up twice a night to wee.
It's insane. I say this to women all the time. They come in, they go, oh, no, but I don't have a dry vagina. I'm like, you just told me that you're getting up 3 times to go to the toilet overnight. You're tired. What if I could improve that for you? Oh, no, that's not going to work with a little pessary or a cream. And, most of them come back, within 4 to 6 weeks, and they say, that is amazing. That is amazing. And in addition to that, I didn't realize how uncomfortable I was until I became more comfortable with the treatment. It's so easy. It's so effective. It's safe. I don't know anything that's safer to prescribe. And in fact, I don't even think we should have to prescribe it. I think it should be over the counter. It's an absolute game changer. And I think that everyone should at least know about it. All women should know about it, because all women will go through menopause and, make a choice as to whether they not only want to treat GSM, but prevent things, like prevent those architectural changes, prevent UTIs. Prevention is better than cure, right?
Yeah, absolutely. And I just look back, I've been a GP for a very long time, and I look back and think, gosh, so many women that back in the 90s, we would put them on low dose antibiotics, like low dose, long-term antibiotics.
Yep. Which we shouldn't be doing.
When probably, no, they need estrogen.
Yeah, with antibiotics now. And, we don't know what we don't know, but I often think back to, all the years that I was practicing medicine and nursing and examining women's vulvas and vaginas, doing pap smears or delivering babies or whatever it might have been. And I am horrified to say that there must have been so many women out there that I missed, that I just simply because I didn't know, I wasn't taught. And I'm so sorry for that. And I guess that's part of forming my mission in all of this, is to correct the wrongs that I've done, hopefully educate people, but educate my colleagues as well, and say, make sure you know what's normal, so that if it's not normal, you can say that's not normal. And then you don't need to know. You don't need to know what it is if it's not normal, but you need to know to then refer to someone who may be able to help.
Absolutely. And know that women developing incontinence as they age isn't just normal.
It's not just because you've had a baby. Everyone, you've had a baby. There are many women out there who have not delivered vaginally, who have not even carried a baby, who still develop these urinary symptoms, including incontinence. And of course, sometimes there's structural things that are going on, and it is multifactorial. But one big contributor is a lack of estrogen and the changes in the tissue that happen with menopause.
Yeah, Absolutely. I often talk about it's a bit like you've got this sort of old, dry, crusty autumn leaf, and then you give it some estrogen and poof, it's back to being green and lush.
Do you know, I've got a really good analogy that's in my office. I have a water lily and, you can't kill a water lily, but I tell you what, a couple of times I've walked in and it looks so sad, really droopy, hanging over the edges. And I liken that to a menopausal vulva. And all you have to do is fill up the sink, which would be your estrogen, chuck it in for a couple of hours and whoosh, you've got a beautiful water lily again with really vibrant, moist leaves and flowers.
Oh, beautiful. That's what we all want, a water lily.
Get yourself a water lily to remind you.
Excellent. Now, one of the other conditions that you mentioned is something called lichen sclerosis. So talk us through that, because that, I reckon if you did a poll, top 100 women, who knows about lichen sclerosis, it wouldn't be that many.
No, I would absolutely agree with you. And I know that when I went through medical training and GP training and a diploma with Ranskog, it was sort of brushed on, but it was a very sort of, I guess, a textbook thing that I just learn. And I never really got taught clinically what it looked like or what I should be looking for. It's not particularly common, but it's probably more prevalent than I think what is stated, which is about 3% of the population. And that's simply because people don't know what it looks like. They don't know what they're looking for. And then once again, women are not presenting with these things because of shame and embarrassment. It's a chronic inflammatory dermatological condition of the vulva and of the perianal area. And it usually presents with itch. That's the predominant symptom, chronic itch that doesn't go away, worse at night. And I guess, like some people do come in with no symptoms. So 10 to 15%, I think, are asymptomatic. And I know now that as soon as I started to really dive into this area, I started to look every time I did a pap smear or what have you, and I was starting to diagnose asymptomatic women just through the look of what happens. So when it's in an active process, there are skin changes, pallor, sort of white plaques around the vulval area and involving the perianal area and the perineum as well. So in a sort of a typical textbook picture would be a figure of 8, if you like. But over time, if it's not treated, because it's a chronic inflammatory condition, it can lead to architectural changes. So the outside flaps, so the flaps can become sticky. This is what I tell my patients. So really simple terms, they can become really sticky and they can kind of stick together. So you get fusion between the labia minora and the majora. You can get clitoral hood adhesions, and in extreme cases, it can really join together so much that the vaginal introitus is virtually gone. I mean, I've seen a couple of older women who have pinholes, which obviously is going to, of course, affect sexual function. That's impossible if you want to have penetrative sex, but even affecting urinary function as well, because it's covering up the urethral opening. So it can be quite devastating. And importantly, it can be a pre-malignant condition as well. So it can progress to SCC or squamous cell carcinoma in about 2 to 6% of cases if not treated.
So I'm imagining that women, though, could have like both GCSM and lichen sclerosis.
Yep, absolutely. And in fact, one can sort of not really trigger the other, but because those hormonal changes are really driving the GSM, the hormonal changes drive inflammation as well. We lose estrogen. It's a potent anti-inflammatory everywhere in our body, including in our skin. So this is a time where a lot of dermatological conditions that were pre-existing become worse again, eczema, for example, or there are new diagnoses like lichen sclerosis.
Yes. And then the third thing you mentioned is like chronic candidiasis. Tell us a bit about that.
I think this is really interesting, and I didn't know about this until I started working with a dermatologist a couple of years ago. I didn't even know it was a thing, didn't know it existed. So acute thrush is when you get an overgrowth of candida, which is a normal commensal of our vaginal tract. So you get this dysbiosis, and that can be triggered by many different things: diet, a course of antibiotics, a stint of being unwell, what have you. So that's an overgrowth of candida. CVVC, which is so much easier for me to say compared to chronic vulvovaginal candidiasis, it's a tricky one, is, I guess, a genetically determined hypersensitivity to candida. So really the body recognizes candida as an antigen, so a foreign body, and then they have a maladaptive immune or inflammatory response to that normal level of candida. So it's not that there's a dysbiosis or an overgrowth, it's just that the immune system is recognizing it as foreign and is acting inappropriately, if you like. And that presents as a chronic itch, but it has a particular pattern because candida is estrogen dependent, and that's an interesting thing as well. But it means that this sort of grumbles along throughout a cycle, peaking in the premenstrual week because that's when our estrogen is at its lowest. And then you actually get relief with menstruation, and then it starts to build back up again. So any woman that comes in with this cyclical pattern, chronic itch, which gets better with their period, that's a telltale sign that you might be dealing with CVVC. Unlike acute thrush, it doesn't have that typical cottage cheese-like discharge. It tends to have more of just a watery discharge, maybe nothing at all. And it doesn't necessarily matter if you get anything on a swab. It's a clinical diagnosis and it's treated a little bit differently to acute thrush in that it's going to require a prolonged course of oral antifungals. Compared to another part of the history, which is important to hook into, a lot of these women will go, oh, I've got thrush, and they'll go over the counter and grab, some over-the-counter treatment, which is absolutely appropriate, and they respond to it. But then, inevitably, it starts to build up again. So if there's that history of response to antifungals, then that's also a clue that you're probably dealing with that. Importantly, with any chronic itch, it's important to have a look and see if there's any changes because you might be putting it down to CVVC, for example, but there might be lichen sclerosis there in isolation or in conjunction with or GSM or what have you. So examination is important.
Yeah, which is tricky because I know for lots of women it's, they're embarrassed and they don't want to, again, show their vulva to people.
Yeah, and I think one way to overcome that is to really encourage every woman to examine themselves. I think really get familiar with your own anatomy and what you look like. Vulvas are so unique and everyone is going to have, it's going to be their own. So it's really important to understand what normal looks like for you so that you can say, oh, that's not normal for me. And then that might, drive you to go and seek a practitioner that knows, that you're comfortable with, that can, have a look for you and then, appropriately treat you. But the biggest thing you can do, and it is really hard when you've been told don't look at your genitals or genitals are dirty, to actually get out a mirror and have a look. But it's the number one thing that you can do that can really turn things around.
Yeah, absolutely. And I think, you're right. They are all different, and there's, and again, it's so tricky these days, particularly for younger people who have access to, pornography, and it's becoming much more commonplace, which gives a stylized version of what people think their bodies, all of their bodies, should look like, but in particular the genital region.
Yeah. And I've got to remember that there's lots of women out there who are getting, labiaplasties and sort of creating the perfect vulva. But what on earth is that? Like, I see vulvas all day and, oh my gosh, like they're so varied and so different. I was looking at, my sister has that book. Do you know the one I'm talking about? It's the pocket guide to, look at my flaps, or flap through this or something.
Yeah, there's.
It's a really clever book, but it's beautiful. It's so beautiful. And it includes so many different women with their own vulvas, obviously, from different cultural backgrounds, even some trans vulvas in there as well. And I was looking at it actually with my niece who's 13, 14 and going through it and, just talking about what normal is. And everyone's normal. Everyone's normal.
Yes, Absolutely. And I think you're right. And we will link that book in the show notes because I think it is
Thank you.
good. Yes, I can't remember it either, but that's fine. That's what we can go and research and have a little look because, yeah, so it's an author and I think she got, I can't remember how many, maybe, a few hundred women to send in, de-identified pictures.
I thought that did she photograph them? Was she a photographer?
She may have. Either way, what we want to do is be looking. So these are just pictures of just a bog standard woman. Nothing, they're not models. They're just standard women of all shapes, sizes, ages, as you said, different ethnicities and realizing that there is a huge variation of normal.
It could be really reassuring for lots of people. Like I'd love to get that book and have it accessible, in my waiting room. In fact, I'm going to do that with no warning label because it's just normal anatomy. But I think particularly for younger women as they're going through puberty to be able to, and they're wondering, I haven't seen anyone else's vulva. Is my vulva normal? Being able to look at a book and say, oh God, I'm pretty sure, mine's definitely within the realm of normal.
Yeah, absolutely. Absolutely. And so I think this is it. I mean, what we've been discussing really is that, we've got a wide range of what's normal and that's good. We need to know what's normal. There's several things that can go on that are not normal and that, they need to be diagnosed and treated. And that the treatments are pretty easy. Like it's not big treatment for most of these things. And the treatment is accessible. It's low risks, low side effects. And particularly the GCSM, you're never too late. Like people, if you're listening to this and you're 75 and thinking, oh, well, yeah, it's too late for me. It's not too late.
No. And Lucy, importantly around that, what we know about GCM is it can lag. So there can be like a decade lag after menopause. So often, as we go through menopause or perimenopause, a lot of the symptoms that are more predominant are the hot flashes, night sweats, the psychological changes, the sleep disturbance, musculoskeletal pain. My gosh, I could go on. There's so many symptoms. And yes, of course, the GSM symptoms can crop up at that time. But a lot of women find that they go through and over menopause and they're sort of recalibrated, they're sitting pretty happy, and then all of a sudden they become really uncomfortable or they get urinary symptoms. That's the big thing. A little bit later and they're like, oh, I'm just getting old. And then they go down that pathway of urology referrals and, like you said, the long-term antibiotics, when in fact it could just be part of this picture of GSM, and adding in vaginal estrogen with or without other treatment is so simple, so safe, so affordable. It's a beautiful treatment.
Absolutely. Well, lovely. This has been a great talk with not a vulva mentioned in sight, so I'm happy about that. If people want to connect with you, so where do they follow you on social media? How can they find you?
Oh, that's a good question. I think I am Dr. _Gab Staniforth by memory. Dr. Gab Staniforth, and there's an underscore in there.
That's okay. I'm sure if they put you in,
it'll come up.
Yes. And we will, again, link these in the show notes.
Thank you.
And your website address?
GabrielleStaniforth.com.au. And then if you're local and you want to come and connect with me as a patient in the Central West, my clinic's called the Papillon Clinic and their website is papillonclinic.com.au.
Oh, I love that. So, yes, if you're in Orange or surrounds, you can actually go and see Dr. Gab in person, show her your bits. She'll sort you out. All right, my lovely friend. Well, time to head on with the rest of your day. I hope that you have a fabulous one, no matter where you are and how you're feeling. May your day be wonderful. Thanks for listening, and I will catch up with you next week. Bye for now. The information shared on the Real Health and Weight Loss podcast, including show notes and links, provides general information only. It is not a substitute, nor is it intended to provide individualized medical advice, diagnosis, or treatment, nor can it be construed as such. Please consult your doctor for any medical concerns.